Let's break down our research group's latest study, hot off the press in Nature Medicine. When it comes to gastroesophageal cancer, despite completion of the standard treatment with chemoradiotherapy, followed by surgery, a significant fraction of patients experience disease recurrence. Immunotherapy has emerged as a novel therapeutic approach used in multiple cancers. However, it is not yet broadly effective for all individuals with esophageal and gastroesophageal cancer. How can we predict which patients are most likely to attain improved clinical outcomes with immunotherapy? Our recent study shows that liquid biopsies might provide insight to answering this question. A liquid biopsy is a minimally invasive blood test. This test, through separating the plasma, the liquid part of the blood, and analyzing it by next-generation sequencing, can detect specific footprints of cancer. These footprints are in fact short DNA fragments that cancer cells shed as they die. Scientists call these fragments cell-free, circulating tumor DNA, or ctDNA. And ctDNA may carry changes in the DNA sequence or structure, known as mutations. Our study evaluated 32 patients with operable esophageal or gastroesophageal cancer who received either nivolumab alone or in combination with relatlimab, prio-2, or during standard treatment with chemoradiotherapy. We performed liquid biopsies for these patients at different time points during treatment, observing the level of ctDNA detected. We additionally measured the levels of tumor-recognizing T cells and interpreted the mounting of anti-tumor immune responses in the context of systemic tumor burden dynamics, assessed by ctDNA. Our findings? While historically 2/3 of patients with gastroesophageal cancer treated with standard chemoradiation prior to surgery are alive, after 2 years, we found that, with neoadjuvant immunotherapy added to the treatment regimen, over 70% of enrolled patients had no signs of cancer, and over 80% of them were still living after 2 years. Notably, over half of patients enrolled had major pathological response following tumor resection. Major pathological response means that less than 10% tumor remains after surgery, and it is typically used to measure the treatment effect with neoadjuvant immunotherapy. What is most significant is that patients who had undetectable ctDNA levels following immunotherapy and immunochemoradiotherapy had significantly longer cancer-free survival. Persistent or rising ctDNA levels on liquid biopsy at any time point during the treatment course can signify molecular disease progression and was associated with inferior survival. This can be particularly informative in assessing the actual tumor burden in the heterogeneous group of patients who do not attain complete tumor clearance after surgery. We found that undetectable ctDNA predicted longer cancer-free survival, even for patients with incomplete tumor clearance at the time of surgery. Analysis of ctDNA may more accurately predict clinical outcomes with immunotherapy. More studies are needed to establish the clinical role of ctDNA dynamics in assessing minimal residual disease and potentially guiding treatment escalation or de-escalation decisions.